Good afternoon, and I'm very honored to be here and take my lecture, which is about the nutrition of the septic patient in the critical care unit. So critical nutrition is a discipline which is dealing with all the nutritional and metabolic changes caused by diseases or any medical conditions. For us healthy people, nutrition is called feeding, which is so self-evident, like having a coffee break during these lectures. But if we are talking about the ill, clean nutrition turns into therapy. And as with any other therapy, we have to find the right indication, the adequate dosage for nutrition, and the perfect timing. And this was a very interesting, so to say, eye-opening paper for me to read. I suggest you to read it because it takes a few minutes. Because it really what we are talking about, we are not treating sepsis, we are treating the patients, and we are trying to heal our patients. And we have to think beyond our walls of the ICU. We have to give them the best possible quality of life after surviving critical care. I think everybody has told about this, that sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection, taking so much lives globally, and this is declared a global health priority. And in 2012, there is the post-intensive care syndrome introduced, which is new or worsening physical, cognitive, or mental health status rising after critical illness and persisting beyond acute care hospitalization. And this is, for the last decades, with better awareness, better technological and scientific knowledge, we could improve the short-term survival of our patients. But nowadays, researchers and clinicians have to focus on long-term survival and long-term quality of life of these patients. And this post-intensive care syndrome is very important for us. It's important for our patients, and as you can see, it's very important for the healthcare system because it's a huge financial burden for it. We can involve nutrition in ameliorating our patients' quality of life because we know there's a marked protein loss or muscle loss during critical care, and muscle weakness acquired in the ICU is strongly associated with 1 year mortality after ICU. And a good, adequate nutrition can save lives and give a quality life after ICU. So I've tried to check what the major guidelines are telling about how to feed, how to give nutrition to septic patient. And the SSC guideline has only one recommendation on nutrition, to start early nutrition within 72 hours, which is a very low quality of evidence. It's a weak recommendation. And the ASPEN, the European Association for Clinical Nutrition, has a practical guideline for the critical care nutrition, but it has only one recommendation specific for the septic patient. And it's also telling us to start early nutrition, and after hemodynamic stabilization, and maybe we can supplement it with some parenteral nutrition. What's the problem? Most of the studies are not focusing on the septic patient. They are focusing on a mixed critical care, mixed ICU population. So this is a very heterogenic patient population. They can be medical, surgical, burn, trauma, and even septic patients. Even the definitions have changed over the years, and there are really few RCTs that we can use for our reviews or for our thinking. Sepsis, during sepsis, there's a marked change in cytokines and hormones, and that's really affecting the whole metabolism of the patient. There, as we know, in the acute phase, it's characterized by very strong catabolism, insulin resistance. This is feed resistant. There's a very strong proteolysis, which is also, there's a protein synthesis is suppressed. You can see that every part of the inflammation is affecting the metabolism. There's there is lipolysis, there is a proteinolysis, and there is a really marked gluconeogenesis, and it will be a chronic phase of the sepsis when all this catabolism will start to turn to anabolism. We now know that if somebody is sick, somebody is ill, there's no appetite, our patients even cannot feed, but maybe this is a little bit beneficial for them. Intermittent fasting in healthy patients activates autophagy, and this is a process which is very, it's the only process to remove macromolecular damage, potentially toxic protein aggregates, intracellular microorganisms. And I was thinking about Christian's lecture. Maybe this is the process that is taking out these fibrin nets with all the bacteria in it. And it seems that in animal models, activating the autophagy is protecting age-related illnesses. So even a few weeks ago, I was listening to the radio in the car, and in the morning show, they were talking about fasting diet, and they even were talking about autophagy. And this is, I just got to know this term just a few months before. And if you're talking about animal models of sepsis, we can see that if we are providing early full nutrition to these mice, they will have liver damage, muscle degeneration. But also, if we have these sepsis model mice, full-fed early phase, but we give them rapamycin, which is an activator of autophagy, these mice will have decreased renal impairment. So it seems like autophagy is a crucial repair process to help recover from critical illness. And we could see that there's a very strong gluconeogenesis in the patients. Up to 75% of the glucose need is produced in the acute phase in the body, but it's not sufficient, so ketone bodies will be synthesized also, which is activator of this autophagy mechanism. And in mice models, ketones enhance muscle strength and enhance muscle regeneration. Okay, so if we're talking about energy expenditure, we can distinguish between resting energy expenditure and total energy expenditure. And it seems it's very interesting that in the early acute phase, the two energy expenditure, it's almost equal. So it seems that our patients are hibernating their bodies. And it's really easy to estimate this energy expenditure using lean body weight. You can use the Harris-Benedict equation, or using indirect calorimetry. Most of these really severe septic patients have hemodynamic monitoring, volumetric capnography, so we have all the data we need. There's only few contraindications to nutrition. If there is a compromised microcirculation, tissue hypoxia, it's not wise to start nutrition because it will worsen the metabolic state of their patients. It's been a long debate whether parenteral or enteral nutrition is better for our patients. And the early studies showed that starting early parenteral nutrition causes higher secondary infections, muscle weakness, but the secondary data analysis showed that in this patient population, in the intervention receiving parenteral nutrition, the overall calorie supplementation was higher. So maybe it's the overfeeding of the patient in the early phase which is causing these problems. And also the calories and nutria to RCTs showed later no harm by parenteral nutrition if we are using it in isocaloric as the enteral nutrition. And the other thing that the early lipid emulsions used for parenteral nutrition were only soy-based lipids, which is well known for their pro-inflammatory effect. And the newer modern balance containing olive, fish, and soy lipids, omega-3 lipids, are anti-inflammatory and they don't cause secondary, in fact, don't raise the secondary infection rates. So we think that this first choice should be the enteral nutrition, cheapest, safest, less invasive. And if you are giving even low calories, it helps the GI tract integration. If it's not tolerated, we can give kinetics, we can place a post-pyloric tube or start parenteral supplementation. These are the contraindications to enteral nutrition like mechanical obstruction, bowel ischemia. I would like to point out the high GRV. GRV is standing for the gastric residual volume or atonia. The newer recommendations are against measuring GRV because that's interrupting feeding and slowing down the calorie supplementation. So to avoid overfeeding, we should not start early full nutrition, whether enteral, whether parenteral. But what is early? There's every guideline says another thing. 24 hours, 72 hours after hemodynamic stabilization. And ultimate analysis showed beneficial the early enteral nutrition, less infectious complications, and this is what the SM guideline recommends us to use. But there are some new reviews which found no significant benefit of early enteral nutrition compared to delayed enteral nutrition. But the data was so incoherent, the definitions were so different, the populations were so heterogenic that no meta-analysis could be performed. So this would have been the background for the next slides, which I think will be a practical information for all of us. So on admission, we should start nutritional risk assessment using MAST or NRS scores, but there is a Nutrix score, which is specifically designed for the ICU patient, and it's also a very good mortality predictor as it contains APACHE-2 and SOFA scores, age, and comorbidities. And we have to think that almost 1/3 of our patients are already malnourished at the time of admission. These patients are usually sarcopenic, so losing even more muscle strength is detrimental for them. We should start early enteral nutrition, starting low dose, and gradually increase it. And we should reach the goal energy intake by 7 days. If you're using estimation for the energy, we should give the 70% for the first 5 days, and later we can use 100% or use indirect calorimetry and provide 100% of the measured calculated energy expenditure, but really it's not proven to be better than estimated. The most important, don't overfeed our patients because there is no major difference in outcomes whether hypocaloric and normal caloric feeding is used as long as there is an adequate protein intake. In the chronic phase, we can increase further calorie intake. And what about post-ICU care? Well, we don't have strong data from patients. What we know is usually from healthy patients for prolonged starvation, like the Minnesota starving experiment, But we know that it takes months, it takes years to gain normal body weight, to regain muscle mass, and energy needs can be extremely high. In the protein, our patients don't benefit from high-dose early amino acid supplementation, and it even can be harmful if we provide them very early, very high-dose protein supplementation. But also, if the overall or the average protein supplementation is very low, below the 0.8 gram per kilogram a day, these patients have the highest 6-month mortality. So start low, increase gradually, and aim for this 1.3, 1.5 gram per kilogram per day. And post-ICU, we can go up to 2.5 grams per kilogram per day. And don't forget our physiotherapists. Feeding the patients, giving them amino acids is nothing without early and mobilization. Please take your cameras here because this is the take-home picture. So this is how we should do it as we know now. And what about the post-ICU? We have to create post-ICU departments or have a much stronger collaboration with the post-ICU surgical wards, medical wards, rehabilitation centers, because as you can see, after endotracheal extubation, 1/3 of our patients have taste disturbances 1 month after extubation. They have difficulty swallowing, even pain at swallowing. So 1 week after extubation, the spontaneous calorie intake in this paper was 700 kilocalories. So we should continue tube feeding, and we should use oral nutrition supplements, the SIP feeds, and it's it's cheap. If you can see $1 spent on oral nutrition supplements, these drinks save $52 for the hospital costs, and this is not critical care patients. This is whole hospital patient population. So I hope I could help you, and I hope we can help our patients to give them the best possible quality of life after surviving our help. Thank you.